In acute neurology, the dominant clinical heuristic is time is brain. For every minute an ischemic stroke goes untreated, approximately 2 million neurons die, driving a rigid emergency response. But that extreme urgency introduces a severe risk. It creates a reflex to push potent thrombolytic drugs the moment a patient presents with a focal neurological deficit. Before localizing the blocked artery, the clinician must determine if this is a mimic or if reperfusion would cause more harm than good. A focal deficit, like a facial droop or a dead arm, is simply the end-state symptom of cortical failure. It tells you a region of the brain has stopped working, but it does not automatically mean a blood clot is the cause. Managing a stroke code requires a systematic approach, ruling out mimics, hitting strict hemodynamic targets, and predicting delayed cerebral edema. Confirming true ischemia is entirely a process of exclusion. Identifying stroke mimics is the mandatory gatekeeper before administering any reperfusion therapy. Before a patient reaches the CT scanner, every stroke code requires one immediate bedside test, a fingerstick blood glucose. Hypoglycemia mirrors an MCA stroke via glucose starvation and ATP failure. Todd's paralysis follows a seizure, causing temporary cortical hypoperfusion. Look for a tongue bite and deficits resolving within 48 hours. Finally, migraine auras present with visual zigzag disturbances preceding hemiplegic symptoms. The underlying mechanism is cortical spreading depression, a slow electrical wave moving across the surface of the cortex that generates gradual, marching symptoms. The critical distinction lies in symptom progression. Migraines present with gradual, positive symptoms, like flashing lights or tingling over several minutes. Ischemia presents with abrupt, maximal, and negative symptoms, vision instantly gone or an arm suddenly immobile. Identifying whether cortical failure is caused by metabolic starvation, post-seizure exhaustion, or spreading electrical depression prevents the misapplication of thrombolytics. Once mimics are cleared and ischemia is confirmed, the focus shifts to systemic blood pressure, which is dictated entirely by your reperfusion strategy. As shown on this green dial, if the plan is to administer thrombolytics, blood pressure must be driven below 185/110 before treatment. Post-administration, the target tightens, requiring maintenance below 180/105 for the next 24 hours. Exceeding these targets is dangerous. Pushing pressurized systemic blood through ischemic, chemically lysed vessels leads to hemorrhagic conversion, bleeding directly into the dying tissue. When no thrombolytics are given, the protocol shifts to a much higher ceiling of 220/120. This is permissive hypertension. The body is allowed to run high to artificially maintain collateral perfusion to the ischemic penumbra, the rim of dying but salvageable brain tissue. Dropping the patient's blood pressure aggressively in this scenario cuts off that vital collateral flow. Without high systemic pressure to force blood around the blockage, the dead infarct core expands as the penumbra starves. Acute blood pressure management is a targeted manipulation balancing penumbral tissue survival against the mechanical risk of causing a catastrophic bleed. If the initial non-contrast CT scan reveals blood instead of early ischemia, the diagnosis is an intracerebral hemorrhage. The goal is to stop the bleed immediately. That means a rapid triage of 3 priorities: reverse any anticoagulants, drop the blood pressure, and control rising intracranial pressure. The priority is immediate chemical reversal of anticoagulants. Warfarin requires 4-factor PCC and IV vitamin K. Dabigatran is countered with idarucizumab. ZA inhibitors require andexanet alpha or PCC, and heparins are reversed with protamine. Antiplatelets rarely require routine transfusions. In an acute hemorrhagic stroke, executing this chemical reversal supersedes waiting for advanced MRI imaging. Stopping the coagulopathy is the first necessary action to save the brain. Even when acute interventions succeed, the timeline of danger stretches far beyond the initial hours. Large territory strokes trigger massive ATP loss and the collapse of cellular sodium-potassium pumps. This initiates cytotoxic edema, an insidious, delayed cellular swelling cascade. This cellular swelling peaks between days 2 and 5, creating the highest risk for herniation. In the middle cerebral artery, this creates malignant MCA syndrome. Massive hemispheric swelling develops, forcing a midline shift inward against the rigid skull. Expanding brain tissue colliding with an unyielding skull boundary forcefully redirects that immense, inescapable pressure directly downward toward the vulnerable brainstem. This mechanical crush manifests as a rapidly declining level of consciousness, a blown pupil, and Cushing's physiology, a reflex of high blood pressure and low heart rate, signaling imminent herniation. Intercepting this cascade requires hypertonic saline and mannitol to draw fluid out of the tissue, alongside a stat hemicraniectomy consult to surgically relieve the pressure. The initial vascular occlusion itself is rarely the immediate cause of mortality in these large strokes. The true killer is the predictable, delayed mechanical pressure wave of cytotoxic edema. Clinicians must also monitor for complications caused by the life-saving therapies themselves. This graphic highlights hemorrhagic transformation. As brain tissue dies, the tiny vessels feeding it lose their structural integrity. When blood flow is finally restored, those weakened vessels leak. This bleeding risk multiplies in patients with large infarcts, cardioembolic sources like atrial fibrillation, or uncontrolled hyperglycemia. Stroke recrudescence is another critical consideration during the patient's recovery phase. When a patient experiences metabolic stress or a systemic infection, old healed stroke deficits can suddenly return. No new infarct has occurred, but the old brain injury temporarily fails under the physiological load. Another masquerader is the septic embolic stroke. Sudden deficits alongside a fever, murmur, or IV drug use suggest infected vegetation breaking off a heart valve. Similarly, cervical dissection affects younger patients presenting with neck pain following physical trauma. Post-acute stroke care demands constant vigilance to distinguish between a true extension of the infarct, a therapy-induced bleed, and physiological masqueraders. Managing a stroke is a structured defense fought across 3 distinct temporal zones. In the minutes phase, the imperative is diagnostic accuracy, eliminating metabolic, electrical, and mechanical mimics before acting. In the hours phase, the objective is penumbral survival, holding a strict hemodynamic line to enable either collateral flow or safe thrombolysis. Finally, in the days phase, the focus shifts to countering the mechanical crush of cytotoxic edema and the rupture of hemorrhagic transformation. Mastering a stroke code requires seeing past the immediate focal deficit to manage the entire chronological cascade of secondary physiological failures.